Okay, I have 3 p.m. Central Time. I think it's time that we start the meeting. I would like to welcome everyone to the MD Anderson Cancer Center Integrative Diagnostic Medicine Case Conference. In the past, I have called it the Neuro-oncology Integrative Diagnostic Medicine Case Conference, but I think I would like to emphasize that the principles are applicable to every subspecialty area of medicine. So welcome to everyone. I think we will get started. There we go. This is a special edition. We used to meet in person at a multi-headed microscope. We're now doing this by WebEx event, and I think it's a big advance because we can involve many more people. So I'm calling this a special edition. Now, it's lunch and learn if you're on the West Coast, California. If you're on the East Coast, this is going to be the happy hour special edition. And if you're in Europe, we can call it bedtime stories. And what better way, really, to get prepared for bed than adventures in neuro-oncologic diagnostic medicine. Okay, we always start with a warm-up. So let's do that. Let's start with a gross anatomy challenge. I'm going to make this is gross anatomy 101 for pathologists and radiologists. This is about as basic as it gets, but that's good. No pressure. Diagnosis. Now, again, I would ask that you not unmute your microphone, but you use the chat function. And I can see your chats when they come up. And so far, I'm not hearing a diagnosis. This is, let's see, I've got one. I've got colloid cyst. Colloid cyst. Anyone else? Any other observations? Yes, Sahara Cathcart says cavum septum pellucidum. We've got central neurocytoma. So far, Dr. Cathcart has a 50. That's an F. On a scale of 0 to 100, she has a 50, but that's a high F. It's not a 0. Everyone else has a 0. Now, this is one of our most recent autopsy cases. I mean, this is beautiful. Every slice contributes to the story. Do I hear anything except cavum septum pellucidum? Okay, maybe it wasn't 101. All right, here's a hint. Yes, Dr. Trivedi, et virgae. All right, here's the hint. What you're seeing in the very top panel, if you go looking in the very back here, like so, you're looking at the spleen, the genu. You're looking at the genu of the corpus callosum, and there are 2 leaves to the septum pellucidum. Here's the body of the corpus callosum, and you can see the 2 leaves is not fused. And if you look at the bottom panel right here, this is the splenium of the corpus callosum. So you can see that the hippocampus going back. So the separate leaves run all the way from the genu to the body to the splenium. All right, and let's just look at a little bit higher power. How beautiful is that? You know, you're looking straight into the let's back up there. All right, right here. That is the genu, the body, and then there's the splenium. You're actually looking at the back of the splenium here. It just doesn't get any better than that. So the diagnosis was cavum septi pellucidi et virgae. This is the patient. We did not have MRI scan. We did have CT scan, and I think everyone can see right here, extending all the way from the genu, the body, all the way back to the splenium. Now so these are the cuts that you're seeing on the section. Now, don't you think that this is really beautiful photography of this autopsy case? And this was done by MD Anderson Cancer Center professional photographers. And I always emphasize to our oncologic surgical pathology fellows that they should take advantage of medical photography. They're experts. This is all they do, and they're very good at it. They're much better than you're going to be able to do with the camera that we have mounted in the frozen section suite or with your iPhone. You cannot beat this photography. And down the road, any of you that are interested in academics, I'm talking to the residents and fellows, you're going to need gross photos for book chapters or writing your own book. And it's going to be hard to accrue them if you wait to the last minute. So particularly for the interns, start now. All right, this is a different case, not the patient, but it illustrates the same thing only with MRI. The T1 on the left, a T2 on the right, usually beautiful incidental finding. Question, cavum septum pellucidum virgae, any clinical relevance? Well, how about this? Cavum septum pellucidum virgae, late onset catatonia? Well, yeah, that's pretty serious. Or how about the next one there? Chronic daily headache. Anyone up for chronic daily headache? You better have your cavum fixed. Or the bottom one there, late onset psychotic symptoms. Wow, with the cavum septum pellucidum. Well, you know, I'm feeling very uncomfortable discussing these. Quick question, is there anything that really does exist relevant to the cavum? Absolutely. How about this paper? Hemorrhage and cavum septum pellucidum at Vergi, does it exist? Yes, it exists. Now, what you're seeing in the panel, you see the arrow. This is from publication, and what you're seeing is a ruptured intercommunicating artery aneurysm, and then the two arrows which I inserted are showing a hematocrit level, or that is a CSF blood or CSF a fluid level in the ventricles. And look at this. All right, how gorgeous is that? So here you can see the cavum septum pellucidum at Vergi, and there is a gorgeous hematocrit level, fluid level. So absolutely, there is some relevance. We have seen cases just like this here at MD Anderson Cancer Center. I'm sure many of you have as well. I'm going to make an observation now. Look at the gross anatomy on the left, these three coronal slices, and look at the MRI. That's identical pathology information. Identical pathology information. So I've said this many times before. Imaging is pathology. And conversely, pathology is imaging. It's one specialty. In terms of diagnosis, diagnostic pathology, diagnostic radiology, it's one specialty. And that's the mindset that all of us on both sides, it's really not two sides, it's one family. Okay, let's move on. How about a neurohistology? Neurohistology challenge, H&E challenge, but I'm going to qualify that. This is real life neurohistology. This is not the beautiful textbooks where life is perfect. All right, everybody ready? All right, I want you to identify it. All right, what's this? What is this? This is a surgical specimen. See, that's the problem with it. It's a surgical specimen. You may think, well, I was expecting some beautiful histology of the cerebellar cortex with gorgeous Purkinje cells, et cetera, et cetera. This is real life. And it's important because this was actually a clue. What you're looking at is a clue to where the lesion was located, and hence the differential diagnosis. What is this? Any guesses? This is hard, all right? I've got, let's see, Dr. Hard, meningothelial hyperplasia. Meningothelial hyperplasia, I like that. There are meningothelial cells here, absolutely. All right? You want to take a look, have another area here. You know what's catching my eye in this thing? This sort of stuff. Now, this is why does this look so poor? Why does this all look so bad? It's cauterized. This is cautery artifact. All right. Yes, Ann Kwan, Chief Fellow. Yes, this is cautery. But a cautery is not what the structure is. I want to know the structure. You know, isn't it interesting? See how these cells are looking stretched out, and you have all these blood vessels. Okay. Now I'm progressively making it a little bit easier with each one. Again, can everybody see? Right here, we're looking at these guys. Look along here. All right, out here, down here. No, not yet. Okay, how about this? Recognize it yet? Check out right here in the center. Everybody see that? Look over here. Look right here. See these fragments? Now I'm handing it to you. All right, also, what is this? Out of focus in the center. What is that? What is that? What is this? Anybody putting it together? What is the tissue? The question is, what is the tissue? Now, keep in mind, these cells that you're seeing here are being distorted by cautery artifacts. So you have to take that into account. All right. And then finally, I've got Dr. Trivedi, olfactory epithelium. That's a very interesting guess. I like it. I like it using data. Again, look at this. Look at what they're looking at now. Now we have an area with less cautery artifact, right? So you have this dense collection of blood vessels, meningothelial cells, and this clearly epithelium. Dr. Harb, Zainab Harb, choroid plexus. Absolutely, this is choroid plexus. What is it telling us? It's a surgical specimen. What it's telling us is that the lesion that the surgeon resected is either in or close to or involving the lateral ventricle. Now that's very important. All right, this is the whole mount of the surgical specimen. And again, what you see is all this dense tangle of vessels and the psammoma bodies, the calcifications. Now, here's the problem. Once you start going up to high power, you're going to see those first H&Es that I showed you. You're not going to see any epithelium. Why? Because the choroid plexus, as you know, is highly vascular. Do neurosurgeons like that? No. The first thing they're going to do is cauterize it, cauterize the heck out of it. Right? And you know what? This olfactory, I'm sorry. Okay, I got to get away from the olfactory. Choroid plexus epithelium is very delicate. And you know, you put the cautery to it, it's gone. It's vaporized. All right. And so you're going to have to hunt for the preserved areas, and they're going to be distorted by the cautery artifact. So you know what I've just shown you? What I've just shown you is normal choroid plexus in the real surgical pathology world. It's going to be cauterized when the surgeon takes it. All right, a little bit higher power, again showing some homobodies, and up to higher power like that. And then again, we'll call attention, see the epithelium, you're recognizing it now. This is what you're looking for. You're going to be certain once, but you know what the clue was? The clue were the psammoma bodies and the meningothelial cells. If you're lucky enough to see meningothelial whorls, they're going to be distorted too. The psammoma bodies in conjunction with the high vasculature says, think about choroid plexus. All right, here's the lesion. There's the tumor right there. You can see it's been operated before, but what is it involving? It's involving the atrium of the lateral ventricle. Look on the contralateral side. What's the structure I'm highlighting right here? That is the glomus choroidum, the largest mass of choroid plexus in the atrium of the lateral ventricle. Here's the tumor involving the lateral ventricle and the choroid plexus. Here's the post-op scan of the specimen I just showed you. Yes, that's what we're seeing now in our sections, confirmed. All right, glomus choroidum is the answer. Normal histology. And we say this a lot. The dogma we always tell our interns in pathology is you can't recognize abnormal if you don't recognize normal. Well, guess what? In the real world of surgical pathology, normal looks quite different than it does in autopsy sections and the beautiful biology laboratory and human anatomy laboratory when you have perfect specimens. Our specimens are cauterized, and you're going to have to work for it and use clues. All right, you like that? Okay, this is histology for pathologists, and I have written, initially it was with Peter Berger from the very first edition all the way through the fifth, and now I have Dr. Leo Ballister at UT Memorial Hermann across the street as a co-author. You know what, look at this. This is choroid plexus that we put in this chapter. It's beautiful. Low power, and you go to high power, and you got the beautiful, look at that cobblestone lower left here. That's not what you just saw, is it? This is the same tissue. What you saw looked like columnar epithelium. Why? Because of cautery. Cautery can make epithelioid cells look spindled, and that's what you have to know. So you have to use other clues. But you know what? This is nice to see this beautiful histology, but really histology for pathologists, this is not what we should be putting in these chapters of the book. You know what we should be putting? This is what it needs to be, because this is the histology for pathologists, normal histology for pathologists. And this is what choroid plexus epithelium looks like, all right, when you take the cautery to it. How do you like that? That's just a little observation. Okay, that was fun. Histology. Well, look, we had histology. Let's do some imaging, neuroimaging challenge. I'm going to bump this up from a 101 to a 201. Okay, everybody ready? Here we go. 36-year-old female. All right, diagnosis. What's a diagnosis? I'll give you a second here. Now, you can make a highly specific diagnosis. I'm gonna have a little coffee. Wait for an answer. About another 3 seconds. Yes, I see Dr. Cathcart, diffuse astrocytoma, IDH mutant. That's absolutely correct. All right, here's the sequences. T2 on the far left, the middle is a T2 flare, fluid attenuation, virgin recovery, and the T with contrast on the far right. It's non-enhancing. So we have a non-enhancing diffuse glioma because the T2 hyperintensity enters the cortical ribbon, overlying ribbon, all the way up to the molecular layer. Diffuse gliomas do that. Vasogenic edema, random metastasis, vascular malformation, et cetera, does not do that. Yeah, so this is the T2 flare mismatch. We usually just shorten T2 flare to just flare. If you hear or see flare, it will imply T2 flare. Is there a T1 flare? Absolutely, there's T2 flare. All right, so this is diffuse astrocytoma IDH mutant. Okay, but here's the thing. Is it okay? Is this okay for T2 flare mismatch? I wasn't used to it looking quite like this. I thought this is what it looked like. Large central area of suppression, all right? And we're talking about this area right here. Large central area of suppression with a thin rim of T2 hyperintensity. In fact, look, here are eight different MD Anderson Cancer Center patients, all of which were proven diffuse astrocytoma IDH mutant. They all show large area of suppression of the signal in the center and a thin rim. Look at this. Can T2 flare mismatch look like this? That looks like a really thick, irregular rim, and the suppression is relatively limited. Is that okay? Yes. What we're talking about here is a spectrum of morphology. Now, how often do we talk about that in the pathology world. A spectrum, you have to be familiar. For example, 13 different H&E morphologic variants of meningioma. Pathologists need to be able to recognize those. At least 22 different morphologic patterns of glioblastoma. We need to be able to recognize those. Well, guess what? If imaging is pathology, then imaging will have the same spectrum of morphology or a similar spectrum of morphology as well as we see in our world. We've looked at this before. Look at this panel, 8 different MD Anderson patients with hemangioblastoma. All right, look at this upper left. I even put an arrow to show. That's going to be the tiniest little hemangioblastoma. That's how they start. They don't start fully formed. One a little bit larger, and we're getting bigger. And they can get really large like this with no cyst. So the pathologist has to know not every hemangioblastoma in the cerebellum has a cyst. They can get really big like this without a cyst. All right, look at the bottom row. There's a tiny little hemangioblastoma with a tiny little cyst. And then it can get bigger, it can get bigger. In fact, it can get so big that the surgeon, the neurosurgeon, might even have trouble finding it intraoperatively. That does happen. All right. Well, this is the spectrum of morphology of the clinical presentation of hemangioblastoma. Just one more example. Look at the spectrum of morphology of pituitary adenoma. Let's start with a hypo-enhancing. See the dark area? Hypo-enhancing pituitary microadenoma. Then this one's just right at the 1 centimeter. It's filling the cella. Now we're getting into a macro because it's coming out and larger. And then look at the bottom row. Here's the far left. There's a nice dumbbell tumor cellar, supercellar, bigger, 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 biggest to the far right. Now here's the point. The pathologist, the radiologist has to recognize in their differential diagnosis that pituitary adenoma can range from this or the smaller, even smaller hypo-enhancing, even invisible, where you might have to do superior petrosal sinus venous sampling to even identify the side, to this, to the one on the right. That is the spectrum, at least the size spectrum of pituitary adenoma. All right, I'm sorry, one more example. I just can't stop doing this because I think it's important to show the spectrum so you don't get fixed in your head that there's only one cerebellar hemangioblastoma, big cyst with enhancing mural nodule. Yes, that's the most common pattern of symptomatic cases, but there's a wide variety. Okay, well, here's the spectrum of vestibular schwannoma, at least in terms of size and shape. Look at the one here on the far right. Can you see the little guy right here, right in the center? All right, that is an intracanalicular vestibular schwannoma. This is actually a cochlear schwannoma. And then here again, intracanalicular, but bigger. Now just barely getting into the growing out into the cerebellopontine angle, and then bigger. There's a cystic bottom row in the center, large solid, maybe with some necrosis, etc. This is the spectrum of vestibular schwannoma. So, and again, from the size range, the pathologist, the radiologist has to be able to recognize the full variation and be methodical. Always look at the petrous portion of the sphenoid for these tiny little intracanaliculars. All right, question. The point. What was the point? The point was, is there a T2 flare mismatch sign spectrum? Absolutely. Here are 3 different patients with this really thick, irregular rim of preserved T2 hyperintensity, and the central area of hypointensity is really quite small compared to those classic examples that we looked at before. But that's just part of the variation. And here are 3 examples. And there's the T2 below. And if you compare the T2, look at the most hyperintense, the most T2 intense signal, and compare that area with the T2 flare, and you can see absolutely it is suppressed here and here. That is a beautiful T2 flare mismatch. Okay, so the rim can be thick, and the central area suppression can be relatively small, but at least the central area of suppression is very sharply contrasted. In other words, when you look at all of these, I mean, that's almost black, hypointense in the center, right? So at least we have that. Well, what about this? What about this? Is this T2 flare mismatch? Not only is the hyperintensity thick, if you will, but the hypointensity is not that hypointense. Is that okay for T2 flare mismatch? Well, here's the full sequence. All right, you have the T2 on the left, here's the T2 flare, here's the T1 post-contrast, it's non-enhancing, and typically we only assess T2 flare mismatch on non-enhancing diffuse gliomas. That would be grade 2 and grade 3 diffuse gliomas. All right, again, go to the far left, look at the T2, look at the most intense area and compare that, look at the T2 flare. That is absolutely suppressed. If a negative T2 flare, that should stay with the same hyperintensity. All right, if it's not pathognomonic, it's so strongly suggestive. So you look at the brightest areas, of the T2, look, compare it with the area on the T2 flare. If you have suppression, that strongly raises your index of suspicion that this is going to be diffuse astrocytoma IDH mutant. All right, so the bottom line, relatively subtle central suppression, yes, absolutely. And this is, of course, tissue-proven diffuse astro IDH mutant, grade 2. The point is spectrum of morphology. Diagnostic neuroradiologists are intimately familiar with the spectrum of morphology of all these lesions. It is us, the surgical pathologists, who have to work at it, but we should work at it. We should work at it. It's one specialty. Okay, that was fun. Look at this. This was a new conference idea I had last time, Mysteries from the Medical Record, and we're going to continue it. Okay, I've got another one. So this is actually volume 1, case 3, because we did 2 cases last week. The curious case of the H3K27M methylation. What do you think about that? H3K27M methylation. You know what that is? That is an oxymoron. Oxy, sharp, moron, dull, sharp, dull. It's an oxymoron. All right, and here it is. This is just from a medical record, astrocytoma, H3K27M methylated. All right, this is a confusion, a conflation, if you will, a portmanteau, if you will, of H3K27M, which is mutation, and H3K27ME3, which is trimethylation mark. It's a confusion between those two. Here's the point. If the tumor exhibits an H3K27M mutation, that is going to suppress all methylation at all of the lysine residues. And you're going to have a strongly suppressed or even absent methylation. So it doesn't, mutation, essentially, they're just like they're mutually exclusive, if you will, in diffuse midline glioma, the most common. This is a nice review article in the journal Cancers. Histone H3 mutations, updated view, etc. And I like, look at this diagram. I thought this is really nice. Here's the protein histone H3.3, which is the histone protein most commonly mutated. Less common would be 3.1 and rare 3.2. And look, this is the amino terminal tail. So all these histone proteins have a tail. These are the amino acids using the single letter abbreviation. And look, here's the H3 K27, this is where the mutation happens, most common. And look, they're also the 3 methylation sites, so the 3 methylation sites. Here's the H3G34, which can be mutated to R or V, R most commonly, V less commonly, in hemispheric H3 mutant-driven tumors. Here's another K. This is H3K36, all right, which can be mutated and methylated. Notice that there are other methylation sites. The K27 mutant, when it's mutant, it's going to suppress globally methylation, and that's how you can have when you run immunohistochemistry for methylation signature K27, it's going to be universally suppressed. Notice that there are other modifications. The AC is for acetylation. Look at all the acetylation marks. Phosphorylation. All right, that's also possible in isomerization. Okay, so I'll refer you to that review article. All right, so let's summarize quickly. H3K27M mutation, the big player in all of this, diffuse midline glioma, absolutely. There are other tumors which exhibit it. Maybe up to half of ATRTs could have the mutation. AML, acute myelogenous leukemia, has a certain percentage. Even melanoma can exhibit this mutation. All right. What about reduction or loss of trimethylation? Well, of course, all of the tumors which can have the K27M mutation, because it's globally going to suppress the methylation, trimethylation, certainly they will have it as well. They will have both. And we typically run both antibodies when we suspect diffuse midline glioma. One is a control for the other. They're complementary in their oppositeness. But there are other tumors, listen, there are other tumors which exhibit suppression or complete loss of the trimethylation signature, which do not have a K27M mutation. One of the most important, malignant peripheral nerve sheath tumor, and then very important to us that deal with brain tumors, posterior fossa ependymoma pediatric type or posterior fossa type A. All right, the way in which this can be diagnosed, reliably diagnosed, without methylation profiling, if you're in a center that you don't have that capability or the ability to pay for it, et cetera, You can do it with simple immunohistochemistry for H3K27Me3. If you see suppression or loss of the trimethylation in a posterior fossa ependymoma, that will be diagnostic. And guess what? In C-Impact Now Update 6, that was endorsed before that, and it's almost certainly going to be endorsed in the upcoming WHO 5E, the 5th edition, WHO 2020. Okay, that was a little mystery there. I think we've cleared that up. Okay, let's do a genomic alteration challenge. We'll call it now. This is a 401. I'm really raising the bar here, and it's a genomic alteration challenge. And I'm going to show you in a second why I'm bumping it all the way up to senior level, senior resident, fellow, maybe even junior attending, assistant professor 401. All right. Okay. Here is our patient as T2 flare sequence. What is the likely molecular alteration of this diffuse glioma? All right, I'm gonna take a second here because I'm throwing out the challenge, and we'll see if anybody wants to chat in, share some answers, maybe not. Give you a few seconds. What is the most likely molecular alteration? Now keep in mind, I'm calling this a 401, not a 101. So if you say this is diffuse midline glioma of the thalamus, H3K27M mutant, you know what I call that? I call that a 101. That's maybe even kindergarten at our level, right? Okay, let me give you a hint. Here's the hint. This is bithalamic, not unilateral. Bithalamic. Is there a difference in molecular drivers on balance between unilateral thalamic diffuse astrocytoma, diffuse glioma, and bithalamic? Yes, absolutely there is. We've known for quite some time now, several years actually, that bithalamic diffuse gliomas tend not to be H3K27M mutant. All right, and I see Dr. Singh, good guess, G34R. No, those go with the hemisphere. Now remember, this is a 401. It's a EGFR exon 20 insertion, small insertions. Okay, and less likely exon 7 involved. All right. Now, why didn't you know that? Why did you not know that? That's what makes it a 401, because this is just April 2020 in Acta Neuropathologica. All right, this is last month. And by last month, I mean yesterday. Okay, so we're talking about currency now, staying up with the literature. Check it out. Pediatric bithalamic gliomas have a distinct epigenetic signature and frequent EGFR exon 20 insertions, all right, resulting potential sensitivity to kinase inhibition. Let's look at the abstract. Just look at the underline. Bithalamic gliomas harbor frequent mutations in the EGFR oncogene, only rare histone H3 mutation, in contrast to the unilateral counterparts we just said. These EGFR mutations are either small in-frame insertions within exon 20, which is the intracellular tyrosine kinase domain, or missense mutations in exon 7, which is the extracellular ligand binding domain. All right, and this is a nice diagram that comes with the paper. And again, here you can see, here's the exons listed up here. Here's exon 20. There's the tyrosine kinase. T right here, see in the green, that's the transmembrane domain. And then here, way out here, there's exon 7. That's the furin-like. That's going to be the ligand binding. So, and look at the number of the triangles. These are the cases that all had either the insertions or the point mutations. All right, so they tend to cluster there. Now, here's the conclusion. This is why it's important. Other than being a diagnostic signature, this study identifies a promising genomically tailored therapeutic strategy for bithalamic gliomas. I like that phrase. We're going to do phrase watch, word watch, phrase watch periodically in this conference. Genomically tailored therapeutic strategy. That's a pretty cool phrase. I will remember that one. Okay, let's move on. Neuroimaging challenge 201. So we'll make this one a little bit easier. Patient, 34-year-old male. All right, here we go. And you see the representative sequences. Okay. And the first thing I'm going to ask, of course, is what's the diagnosis? What's the diagnosis? What you're seeing up here, let's just clarify. Here's a T2 on the left, T2 flare, T1 with contrast. So it's non-enhancing, all right? And you're seeing, I'm showing you 3 additional T1 with contrast. Okay, actually the axial is the same, but the coronal and the sagittal, I'm showing you more. What's the diagnosis here? Easy breezy. Yeah. Okay. Yeah. Dr. Trivedi got it. Dr. Harb got it. Dr. Wu got it. All right, absolutely. Diffuse astrocytoma, IDH mutant. Actually, that was a test for everyone if you were paying attention, if you learned something. But see, that's not the question. The diagnosis, yeah, absolutely. That's not the question. That's not why it's 201, right? This is 101, correct? All right, here's the question. What type of surgical procedure was performed? Okay, I'm going to wait just a second, see if someone wants to chat in with what type of surgical procedure. And of course, you're going to have to, and you're going to have to justify it and why, right? You can't just guess, right? And if you get it right, appear brilliant without justifying it, because maybe you're not brilliant, maybe you're just lucky. You like that? Okay, let's go back and we'll look at the scans again. Look at the scans. What type of procedure was performed? Question: gross total resection? Increasingly, it appears that might be a good thing to do with IDH mutant tumors. All right. Okay. Here's the T1 with contrast. Okay. Let's bump it 201. Here we go. What is the name of this sulcus? Here's our tumor. Here's a sulcus. What's the name of the sulcus? Anyone know the name of that sulcus? Yes, calcarine. Right. Dr. Cathcart, Dr. Trivedi, calcarine. Yes, Dr. Wu. Very good. Alex, good job. Hint, it's this one. This is from a normal brain. Yeah, it's the calcarine. This is the calcarine sulcus. All right. Let's take a few questions here first. All right. Let's have a little fun with it. What function is associated with it? What is the etymology of calcarine? What is the ventricular landmark? All right. Visual cortex, right, Dr. Trivedi? What is the ventricular landmark? How do we recognize the calcarine cortex macroscopically, not micro, macroscopically on cut section? All right, in a surgical specimen or at autopsy. All right, Dr. Trivedi says the line of Gennari, that is correct. All right, what is calcarine? Calcarine means referring to the calcar avus. So the calcarine fissure, all right, produces the calcar avus. That's the spur of the bird. All right, imagine a rooster, right, the spur on the feet. All right, that's what it looked like. And you see, this is from Wikipedia there, the calcar avus. The calcar avus, which is the ventricular landmark of the calcarine sulcus, is produced by the calcarine fissure, bird spur, exactly. And here's the line of Gennari. And well, let's look at this. Many people may already know this. Francesco Gennari, first observed in 1776. That was a landmark year in the United States. As a medical student at the University of Parma. Hey, no pressure, residents, fellows. He was a medical student. I know it was a simpler time. Low-hanging fruit, right? Okay, what type of procedure and why? What was the procedure? The bottom line, all I'm looking for is not gross total resection. Why would you want to give a quadrantanopia to the patient? It was a biopsy. Why? Because they were worried. They were worried about losing that quadrant of the visual field, correct? All right, so what's the next step? What do you do? This patient's at MD Anderson right now. What do we do? You want to just roll the dice? It is Texas, right? Let's just go for it. Watch and wait, follow, chemotherapy, radiation. How about diffuser tension imaging and functional imaging for optic radiations? Let's see how close the tumor comes. Maybe it's displacing the optic radiations. All right, so this is a recent paper, World Neurosurgery, optic radiation DTI, tractography. All right, Myers loop, and here's the figure. We are very good. Our neuroradiologists at MD Anderson are second to none in generating the tractography and also in functional MRI. All right, beautifully looking at it. Oh, I was going to ask a question. Ooh, I was going to say, do we always need sophisticated imaging techniques like this to see the optic radiation? Does sometimes nature perform an experiment that shows us? Yes, absolutely. Check out how beautiful is this, going from the lateral geniculate nucleus all the way back, all right, to the calcarine fissure. You like that? Outlined by vasogenic edema from the tumor. That's beautiful. Okay, patient number 2, 36-year-old female. We go, resection specimen, and what you can see here, this is clearly gray matter, cerebral cortex. This is going to be white matter. Here's the gray-white junction, all right, along here. And you see a tumor, glioma, and the white matter. Here's a little bit higher power. And one more. Differential diagnosis. What do you think? Just based on H&E. You can always generate a differential diagnosis. Differential means not the absolute diagnosis, just a differential. Any ideas? Anyone want to play? It is a diffuse glioma. What does the morphology look? Yeah, Anquan, thank you. And oligodendroglioma. Why? Because the cells are regular, round, monotonous, and even though the histology, it's an outside case, is suboptimal, you can see halos around some of these nuclei. If you look at maybe an area like this, I can see halos there, some here. All right, yes, oligo has to be probably number one on your list. Then you could go with astrocytoma. Is it absolute? No, it's not absolute, but it's very suggestive. All right. This particular case, the first thing, of course, we did was run a simple immunohistochemistry, 24-hour turnaround, IDH1R132 for the mutant protein. It was negative. So there's no support from that for IDH mutant, at least for the canonical mutation. All right. So the diagnosis, listen, the diagnosis rendered based on the H&E and the immunostain, IDH1R132H, which was negative, was diffuse glioma, because we can't tell definitively if it's oligo or astro, negative for IDH1P protein, P.R132H expression in OAs, not otherwise specified because we can't pin it down. We don't have all the molecular data. Got it? Now, hypothetical. This did not happen. This did not happen, but imagine a hypothetical scenario. If this is useful exercise, the patient's primary care physician says they can't wait, they can't delay treatment because the patient's status, they need to start now. Should we treat it as an astro or an oligo? They're asking you, what do? We have to treat. All right, it's hypothetical. You got it? So the question then I will ask you, what should you do to give the best advice to the primary care physician quickly? What can you do? What else can you do? You've got the H&E, which is strongly suggested. Okay, Darshan Trivedi says ATRX immunohistochemistry. ATRX immunohistochemistry is very good. Why? ATRX is good because, and Dr. Harb says P53, that would be the second best thing. All right, here's how it works. Correct. ATRX, if it is lost, if expression of normal ATRX is lost, that is mutually exclusive with 1p19q co-deletion, so the tumor cannot be an oligodendroglioma. It's going to be a diffuse astrocytoma. Now, you're not going to know if it's mutant or wild type, right? Okay, and then Dr. Sanjay Singh, preeminent Texas Medical Center neuroradiologist, just gave the correct answer. If you don't mind, Dr. Singh, I'm giving you full credit. I'm going to hold off for just a second. Dr. Singh is correct. What do you do quickly? All right, worst choice is you would tell the neuro-oncologist, I'm going to order PCR, our next generation sequencing or methylome profiling, and I'll have an answer for you in 7 to 10 days. And they're telling you this is urgent, we can't wait. That's the worst. Better choice, IHC for ATRX, right? Or as Dr. Harb suggested, P53, you would run at the same time. How does P53 work? Here's how P53 works. Its positive predictive value is very high when it labels, let's say 90-95% of the glioma cell nuclei in the context of a diffuse glioma, grade 2, grade 3, it is highly predictive of TP53 mutation. Its negative predictive value is extremely low, which means if the P53 is negative, that does not mean that there is not double negative, a TP53 mutation. It might be mutated, it might not. If there are 10%, 15%, 20% of the nuclei labeled, it's meaningless. It's essentially a negative study. It has to be up there, the majority. And you know it when you see it, okay? So both of those you would run. But neither one of those, listen, neither one of those is the best choice. The best choice was given by Dr. Sanjay Singh. Now, Dr. Sanjay Singh, all right, Dr. Sanjay Singh is a neuroradiologist. He knew that we might be able to get the answer in less than 60 seconds. Less than 60 seconds? Yeah, look at the pre-op imaging, stupid. Sorry, I didn't mean to say stupid. I am making no, I meant to say lazy. Okay, anyway, we'll scrub that from the tape. Look, this is this patient. This is the patient. Check it out. What's the diagnosis? Is it oligo? It really looked like oligo on the H&E, didn't it? We put that number 1 because the halos, et cetera, the monotony. No, this is T2 flare mismatch. Dr. Singh was correct. All right, and that's right, Dr. Harb. Diffuse astrocytoma IDH mutant in a femtosecond. A femtosecond. How good is that? In fact, you could probably do it in an attosecond. That's 10 to the minus 18. Femto's only 10 to the minus 15. It's super fast. All right, why? T2 flare mismatch, so it's a diffuse astro IDH mutant. It turned out to be, it was sequenced. In fact, Oncomine was performed. Turned out this was an IDH2 or 172M mutated, so one of the non-canonical mutations. So the T2 flare mismatch prediction was correct, even though the IDH1 or 132H antibody is negative. It was not that one. It was one of the non-canonicals. I guess you know another way you could look. Think of this for just a second. I know Dr. Cathcart said reflex to PCR for the non-canonicals. Absolutely, you would do that. How about this though? How about viewing a positive, not a negative, a positive T2 flare mismatch sign as a surrogate marker for non-canonical IDH1 and 2 mutations, as well as IDH1, the canonical R132H, but it works for the non-canonicals as well. Oh, how cool is that? Had you thought about that angle? Well, here's a case in point. All right, from last week, all of our materials current. Did you like that one? I really like that one. Okay, the next case comes to us courtesy of Dr. Zainab Harb, a frequent attendee to this conference at Bay State Medical Center in Springfield, Massachusetts, pathology resident, future neuropathologist. All right, patient number 3. This is Dr. Harb's case, 61-year-old female. All right, here's the imaging. All right, you recognize the sequences? Give you a second just to put the sequence together. This is for the pathologist. All right, we'll label them for you. T1 on the far left, T1 with contrast, second from the left, T2 flare. And you see the mass. The question is differential diagnosis. What are we talking about here? Clearly, this is an intraventricular mass. Now, let me issue a caveat about, quote, intraventricular tumor. That can have 2 meanings, and you have to be very careful when you read it in the medical record, you hear it from a colleague, etc. It can mean one of the tumors which we consider essentially a pure intraventricular. Now, this includes tumors that arise from the wall of the ventricle, like ependymomas and subependymomas that grow into the ventricle. So 99.9% of the mass of the tumor, even though they originate from the wall, is in the ventricle. And like choroid plexus tumors, etc. Those are what we as pathologists will consider intraventricular. Now, glioblastomas of the adjacent parenchyma can grow into the ventricle, and you can have 90% of the mass of a glioblastoma in the lateral ventricle, but that is not an intraventricular tumor. Guess what? If you wanted to say that, then all 120 primary brain tumors or intraventricular tumors can be, and that's your differential diagnosis list. So just be careful with that. And there's a paper I will show you at a future conference in which I was a guilty party to a paper that did combine the two. And I will admit guilt when I'm guilty. It's very simple. Listen, if you're going to lump in a glioblastoma that grows, and it's in the parenchyma, it's diffusely infiltrating, but it also grows in the ventricle, and there's a big part in the ventricle, and maybe the neurosurgeon goes in and takes the part in the ventricle out and calls that intraventricular tumor. If you're going to call that intraventricular tumor, then you're probably one of these people that lumps myxopapillary ependymomas of the lumbar cistern in with intramedullary ependymomas just to increase your numbers for a study, when they're night and day in terms of their biology, in terms of surgical treatment, et cetera. Okay, that's just editorial comment. All right, we're talking about intraventricular tumors. I think everyone knows the differential intraventricular tumors. Choroid plexus tumors, which would be papilloma, atypical papilloma carcinoma, choroid plexus meningioma, that's what we should call them. We call them intraventricular meningioma. We should call them choroid plexus meningiomas because that's where they come from. Ependymomas, subependymomas, central neurocytoma up in the lateral ventricle foramen Monroe, subependymal giant cell astrocytoma, all right, et cetera. All right, here's the smear, a beautiful smear. I will compliment Dr. Harb on this. It's like done and done. You don't even have to wait for the frozen section, the architecture to call or go into, if you're suited up, go into the operating room and tell the surgeon, this is meningioma. Good job, Dr. Cathcart. Yes, beautiful meningioma, absolutely. You can see these whorls. Look at this beautiful whorl up here. Whorls everywhere. There's another gorgeous whorl. Psammoma bodies, right? Which are not smearing. The tissue's being distorted around. Beautiful meningioma in the ventricle. Here's the frozen section. Again, you see the psammoma bodies. Beautiful permanent section. You can see transitional. There's a lot of we could call this transitional meningioma. It's also got some spindle areas here. You could call it mixed fibrous and transitional if you want to. It doesn't really matter. Okay, mitotic index on H&E, and this is the gold standard for WHO 2016 grading of meningiomas. It's H&E, not phosphohistone H3, it's H&E. fewer than 4 mitoses per 10 high power fields. Quick question, can I ask you a grammar question? Is it less than 4 mitoses per 10 or fewer than 4 mitoses per 10? What is it? Well, people are going to know what you mean either way. And I mean, is there really any penalty for being ignorant in grammar or English? No, but you know what? You're going to irritate some people, and maybe you irritate someone who's reviewing your paper or listening to you in public, or a future employer, and they think you don't know the difference between less or fewer. Here's the bottom, it's super easy. If you can count it, there are exceptions. If you can count it, it's fewer. You can count mitoses, it's fewer. If it is a continuous thing that you cannot, quantitate, if you can't count it, then you can use less. All right, I'm having less and less patience with you. Do you understand? Okay, it's fewer. Anyway, meningioma, WHO grade 1, that's a diagnosis. All right, Dr. Harb, among the immunostains that were run, here are 2 immunostains that she sent. Very nice photos. What are they? I'm going to ask you what they are. 2 immunostains, both were relevant to prognosis. It was warranted. This is not like running CD45 for an obvious meningioma or GFAP or S100 or any of these other crazy markers that you'll see. Keratin, 5 different keratins. Both of these are relevant to prognosis. What do you think they are? Well, how do you approach it? Well, of course, it's not just is it brown a little and brown a lot. The question is, what is the pattern? All right, well, what are they? These are both nuclear. Those are nuclei that are staining. So the differential, think of it this way, is a differential diagnosis. The differential diagnosis for what each one of these is, yes, Dr. Sergio Piñovada says Ki67 on the left. So did Dr. Kwan, Ki60. Everyone's liking Ki67 on the left. And you are exactly correct. The differential, all right, is nuclear immunostains. Now, if you, and yeah, Dr. Cathcart says maybe progesterone receptor on the right. Okay, we're going to get there, Dr. Cathcart. Now look, if you had attended the 34th annual review, all right, Stat 6, all right, that's creative for thinking that it might, I say Sergio just said Stat 6, which would be nuclear, and it would be aberrant translocation, which would mean that this is a solitary fibrous tumor / HPC, but since it, rather than meningioma, that's a great thought. And it would be diffuse like that, okay? If you had attended the review, then you would have said the slide, all right? Immunostain localization, it's critical. Is the stain supposed to stain cytoplasmic, either in a diffuse pattern or a Golgi, perinuclear Golgi? That's a different cytoplasmic pattern, has a different differential diagnosis, different tumors characteristic stain for it. Membranous pattern, nuclear pattern, extracellular matrix, that would be like, say, collagen type 4, or combinations of the above. Like what? Oh, I guess I didn't show it. Okay, nuclear. Here's the immunostain localization. This is not complete, but this is a pretty good list of most of the immunostains that we use diagnostically, clinically, that stain nuclei, plus or minus cytoplasm, but nuclei is what counts. There's P53. Look at Ki67. All right, right there, number two on the list, et cetera, et cetera. This was Ki67. So good job. But you know what? For everyone who guessed Ki67 on the left, and it's relevant to prognosis, correct? Yes, it's relevant. It's not the criterion. H&E mitotic figures is the strict criterion by WHO 2016. But you know what? All of our neurosurgeons are going to want to know what the Ki is, and they're going to get worried if it's getting up over 10%. Then they're going to get where they're going to watch. They may shorten their surveillance, imaging period, et cetera, et cetera. Okay, that's good. What about the one? So that's a 50%. So far, everyone who guessed Ki67, you have a high F. A high F, but you have to get the right-hand panel in order to get an A, 100, okay? What do you think? Let's go back to our list. Do you think it might be on this list? All right, there's the Ki67. We already awarded that to the one on the left because we know it's a WHO grade 1, low mitoses. That's going to be the Ki. All right, what is this? What is this guy? All right, how about progesterone receptor? Well, 2 things. Number 1, this would really be strong and diffuse for PR. Definitely many meningiomas, not all, a percentage, I don't know, 20%, 30% show PR. ER? No. ER? No. Not estrogen receptor, PR, absolutely. Is it a therapeutic target? Is it useful? Is it useful therapeutically? No. Has it been tried? Are you kidding me? It's been tried like crazy. All of the hormonal therapies, all of the agents have been tried exhaustively about 20 years ago, and unfortunately, meningiomas, the ones that are problematic, that can't be resected along the skull base, maybe the aggressive ones, et cetera, they're not dependent. All right, on progesterone receptor, they're not hormonally dependent. They don't care. All right. Okay, here's the thing. But there's progesterone receptor. That was a great guess. Look, this cannot be. The reason why the panel on the right cannot be progesterone is because I said they're both relevant to prognosis, and there is no correlation with prognosis, how that tumor is going to behave biologically if left untreated, et cetera, that relates to PR. And believe me, it was studied extensively. So what is the nuclear marker that is relevant to prognosis? And the answer is H3K27. Here it is, the trimethylation. Yes, exactly. And look, there it was at the very bottom of the list. H3K27 and mutant, and is certainly nuclear. H3K27 trimethylation, also a nuclear stain. But now, so this is H3K27ME3. It is the trimethylation mark, and it is not suppressed. It's not reduced. It's not lost. Question. Okay, fine, you got that. Now that you know what the marker is that good or bad that it's not suppressed? Well, now we have to go just very quickly here. Let's run through molecular classification of meningiomas. Just the important stuff, just the basics. Nice paper 2016, Genetic Landscape of Meningioma. All right, look at this. This is a great little diagram. NF2, look up here, top left. NF2 is the single most common, look at the width of the bar here, the single most common mutated gene in meningioma, all meningiomas, including sporadic, is NF2. It occurs across all grades. Look at the far left, grade 1, grade 2, grade 3. All right, then you have TRAF7, KLF4. Look at secretory meningiomas. Secretory meningiomas are characterized by the combination of KLF4 and TRAF7 mutations, et cetera, et cetera, et cetera. And this is the direction that we're moving. There was TERT promoter. Someone had said TERT promoter. Unfortunately, we don't have a good immunostain for that. All right, here's a paper, 2018. Active neuropathological loss of histone H3K27ME3 identifies a subset of meningiomas with risk of recurrence. All right, here's just showing intact in A, loss in B, with endothelial cells being the internal positive control. All right, and then look at the survival curves of retained, which are the black curves, versus loss, very dramatic. All right, here's another one, dystrophin gene, DMD, deletions, characterized subset of higher grade meningiomas. Look at this. Look at the curves over on the left. In the blue is dystrophin retained, and then with the dystrophin lost. All right, in the red here. Okay, TERT promoting mutations, risk of recurrence. All right, same thing. Look over here. This is the red, green, and gold. These top three curves. All right, along here, all TERT wild type, and look at the blue. All right, very, very, very dramatic. TERT promoter bad. All right, here's a second paper, independent, 2018, TERT promoter mutations for prognosis. All right, again, the same curves. All right, prognostic significance of TERT promoter mutations, exactly the same thing. Underline, significantly worse prognosis. All right, significantly shorter survival. All right, what percent of meningiomas show it? Here it is right here, only 8%. Okay, listen, only 8%. But you know, if you're those 8 patients out of 100, this is critical to you. We absolutely should be looking at it. We should be profiling like NGS, methylation profile, whatever platform on all of these cases. BAP1, all right, one more. We're almost done. BAP1 mutations, bad actor. All right, and here we can see. Look at the very top up here. You can see grade 2 and grade 3, and here's the SMARCY1 clear cell, BAP1 for rhabdoid papillary. Here's the TERT promoter mutation. See, they're primarily grade 2, grade 3. All right, and so here we go. Adverse molecular alterations, BAP1, dystrophin, TERT promoter, H3K27 trimethylation mark, and then specifically associated with histologic types, SMARCY1 with clear cell, which we know is a grade 2, clear cell and chordoid are the 2 grade 2s, and then BRAF V600E and rhabdoid. What? BRAF V600E, I thought that was supposed to be a good mutation. I thought you wanted the tumor to have BRAF V600E. It's targetable, it's treatable. If you're thinking it's a glioblastoma and it's BRAF V600E positive, it's probably an anaplastic PXA. That's good. Not always. All right, rhabdoid meningioma section. Look, now this is something that I know everyone knows intrinsically. I'm just reinforcing it. The same mutation, the identical mutation, or let's just call it molecular alteration. All right, because it could be any form of molecular alteration. The same alteration in one tumor type versus another tumor type can be day and night. In some cases, it will characterize a tumor with a worse prognosis. In other instances, a different tumor, that tumor will have a better prognosis. It all depends on the biology, the pathophysiology, when the gene becomes activated, et cetera. All right. So I know everyone's aware of that, just reinforcing it. All right. Again, I thank Dr. Harb for that beautiful case. All right. We're almost done. 5 minutes to go. This is the last segment of the conference. I think I may continue this one. This is a new feature, a new conference feature for May 1st. Currency of knowledge-based challenge. This will test the currency of your knowledge base. All right. And I know you're probably thinking, well, I already have done that once a few minutes ago with the ACTA paper. Well, I'm about to do it again. All right. So here we go. 18-year-old male with a history of glioblastoma. This is the question. Here's the challenge for you. You ready? What disease should you think about, i.e. you need to rule it out, based on the presence of the circle feature in the imaging studies I'm about to show you? Everyone understand? The patient has glioblastoma. Absolutely. I'm not asking, I've already told you the patient has glioblastoma, so I don't want glioblastoma. You know that. I want to know, in this 18-year-old patient with glioblastoma, based on the feature I'm about to show you in multiple panels, circled to make it easy, what disease, what setting should you at least think about and say, you know, I better take a look at it because this is here, because I see this in this context, I better make sure that the patient doesn't have the answer. Okay, everybody ready to play? Here we go. Now, obviously, here it is. Obviously, you have to know what the feature is in order to get this game correct. If you're looking at this, maybe you're a pathologist, and that's okay, surgical pathology fellow, and you're not seeing a lot of imaging, and you may not recognize it. That is fine, because for the neuroradiologists, any neuroradiologist want to, or how about a pathologist? Any of the pathology fellows or whatever want to what am I circling here? Now, this patient's had a craniotomy and there's stuff going on with the ventricle. That's not what we're talking about here. We're not talking about the glioblastoma. We're talking about what is being shown in all of these T1 with contrast images. What is it? I'll give you a hint. It's an incidental finding. And if you see it in a normal patient, you think nothing. Sanjay Singh, all right, DVA, all right, yes. Developmental venous anomaly. That is what it is. Now, in the context, listen, in the context of a pediatric patient presents with glioblastoma and DVA pops up, maybe 2 DVAs, maybe 3. And by the way, this is the most common location, right here, frontal parietal lobe. What should you think about? And again, what was the name of this challenge? Was this the knowledge currency? How current is your knowledge base? Are you following the literature? Are you keeping up with the literature? That's what the challenge is. Okay, well, let's go to the American Journal of Neuroradiology. When was it published? Yesterday, day before yesterday, 2 days ago. Okay, now if you're saying, no, wait a minute, you expect us to keep up with the literature came out 2 days ago? Yes. If I do, you have to. I'm the old guy. Why should I work harder than you? Especially, I'm talking to a bunch of trainees. You have infinite energy, correct? Okay, this is a fun one for me. All right, here it is. Neuroimaging findings in children with constitutional mismatch repair deficiency syndrome. That is serious. All right, CMMRD is serious business. All right, this paper published 2 days ago in AJNR. What did they find? They found that the patients had glioblastoma and AAs, et cetera. Well, look at this. DVAs, non-neoplastic stuff they found, DVAs in 12 of the 14 patients, 85%. Isn't that fascinating? Why? I don't know. Okay. Okay. So the present case, what about the present case? What about the present case? MD Anderson patient. Immunostaining for mismatch repair protein expression was performed by me. I ordered it. All right. Based on the NGS. What did I see on the NGS? On the next generation sequencing, Oncomine profiling, what I saw about 40 molecular alterations on the NGS. Did I see any of the mismatch repair genes circled, altered? No. No. Well, why then would I suspect mismatch repair if all of the mismatch repair genes were there and they are on the panel and none of them are called, well, the answer is because the one exception to those showing up is the screen that we use is primarily designed, all right, to identify somatic alteration. So somatic mismatch repair, which is a very active mechanism, important mechanism in many tumors, will absolutely be picked up and identified. But there's a separate list, a separate screen. It's because that's what they use to subtract out. They use the native DNA, normal DNA, if you will, to subtract out. So it makes it easier to screen, to make the calls, if you will. But what did I do? So the data wasn't there in NGS. So how did we make the diagnosis in this case? If we could, we did it with immunohistochemistry. Holy moly. I had the answer that when I looked at it and I thought about it, and the tumor looked horrendous. It looked it looked like, you know, just the worst glioma, pleomorphic, et cetera. I thought, let's just look. Let's run the immuno. What happened? PMS2, one of the classic four. PMS2, loss of expression in tumor cells. Now that could be somatic. That would have shown up in the somatic screen, and normal cellular constituents and the endothelial cells. That was the key. If it's lost in the normal constituents, that's what makes it constitutional MMR. Here's the report. CMMRD. All right. I say history. This was a second resection. This is the initial resections where we made the diagnosis. Do you like that? I think it's kind of cool because do you know who made this diagnosis and who made this diagnosis possible? The patient, we would understand it. It was the pathologist, because the pathologist knew stuff. We know stuff, right? Same thing with diagnostic radiology. We know stuff, and that stuff can save patients' lives. It can help patients every single day of the week. All right, that's it. I am done. I finished on time, 1 minute over. Follow me on Twitter. Thanks to everyone for attending. And really, without you, there's no conference. And I will see you next week.